Hello everyone. Welcome back to my YouTube channel. It's a great pleasure to have you rejoin us. I'm wanting to do one more video before we leave this beautiful Maranacook Lake back for the city. And I would like to start off today by doing something a little different. And this is a part of the programs that I try to provide to keep this YouTube channel fresh. I like to invite interesting people and talk about interesting topics that might be of interest to all of you varied viewers. And today I have a very special topic with a very special guest, Dr. David Faigin. And I would like to start off today by rolling the clock back 30 years to 1990. And at that time, I was chief of surgery at the Glenbrook Hospital in suburban Chicago. And it was a very, very special time because up to that time, performing a gallbladder surgery required making a big incision in the abdomen and taking out the gallbladder that would lay the person up for 4 or 5 or 6 weeks. Painful operation, a long recovery. And what happened in 1988, Eddie Joe Reddick and Bill Say in Nashville developed the laparoscopic procedure for gallbladders. And so a lot of us went down there and took the 2-day training course. The first day we operated on 3 pigs, and the second day we observed actual surgeries, several patients being operated on. Now I'd like to talk about the pig lab, because what happened was that the pigs would be brought in from the farm. These pigs are very valuable pigs, by the way, and they would be put under sterile conditions, anesthesiologists and so forth, and we would do a surgical technique of the laparoscopic cholecystectomy, and afterwards wake the pigs up and return them to the farmer's truck. And then we would go out and wait till they prepared the next set of pigs. And when they did that, we'd be coming back in, and we'd pass by the farmer's truck, and believe it or not, the pigs were eating grain less than an hour after their surgery. It was remarkable. And so we all came back to our relative institutions and started to perform this procedure very carefully on the selected patients in the beginning. And the patients could go home within a day. And they had very little discomfort in most cases, and they went back to work in a week. Now that was wonderful, but it was new technology. And as a result of that new technology, there were several very, very horrible situations that happened. And I'd like to remind you that what I'm about to tell you, I'm going to talk about two cases. They're both real, but of course they're very carefully disguised so that there's no way that you could identify who they were or anything about them. And so I also am presenting them because I'm chief of surgery at this hospital, but they did occur at other hospitals, so there'd be no way you could identify them. And the first case was a patient came in to have a laparoscopic cholecystectomy, and they put a needle in the umbilicus and then infuse the abdomen with gas to create a space. And then following that, go ahead and introduce a trocar, which is like a little spear. Now, it's not very big. It's less than an inch. It's about a half an inch, but it's a spear. And the umbilical skin is very thin. And if you push a little too hard, it can penetrate too deeply, and it actually can put a hole in the abdominal aorta. And this happened to this patient. It was a young woman, a very experienced surgeon with an excellent track record, very seasoned, been out in practice 15 years. And by the time they could sort the situation out, the patient bled to death. So it was presented at Morbidity Conference, and after that, of course, the surgeon was called in by me to the chief's office, where the chief would say, and I'm playing the chief in this part, although I wasn't the actual chief here. It happened at another hospital. The doctor said to the chief, I'm not sure I can go back into the operating room. This has been a devastating complication. This family has lost this mother, and I just don't know if I can do that. And so the advice was, what I'd like you to do is, of course, take some time off to sort of regroup. But then I would strongly suggest that you see somebody, a professional, clinical psychologist preferably, and preferably somebody that deals with these traumatic instances, and see what can be sorted out in terms of getting you back into the operating room. And so now I'd like to go back, not 30 years, but 16 years ago when I met this wonderful Dr. David Faigin, who is my son-in-law. He married my youngest daughter, and I loved David at first sight. And you'll see why, because David has a very, very good way of explaining things. He's a wonderful human being, and I'm going to ask him to give us some insight. David is a trained clinical psychologist, PhD, of course, trained in the VA system, works with the veterans, especially those with traumatic syndrome and all sorts of difficult problems after they return into civilian life. And David, good morning, welcome, and I'd like to have you address this situation.
Sure. Honored to be here in so many ways. This beautiful day we got. Well, I really appreciate, first off, that when dealing with, somebody like this comes into our office, we're going to be interested in a few things. Number one, we're going to honor the fact that this person is functioning at an incredibly high level, very, very skilled individual, right? With, as you say, years and years of training. And when there's a trauma like this that occurs, it's very easy to forget, so much about all the thousands of days that it went well, that everything was good. But we want to, right off the bat, instill a sense of hope. Of course, this kind of person, that somebody comes in, they're going to say, am I going to be able to come back into the OR again? Okay, is this treatable? And of course, post-traumatic stress is absolutely treatable. We can help people with all sorts of struggles. But number one, I want to hear about the history in this person's life and practice. That's important for them to share. And I want to know about the kind of milieu, the professional milieu. And of course, what we'd want to get into is the details of that day, that operation, what went wrong, and to get a sense of what that person's appreciation of it was. Where are they placing blame? Where are they? What are they still running over in their head? Where's the pain? Of course, there's sadness and grief, and there's all sorts of things. But we really want to, one of the things I just think about with a surgeon is, again, like any high-level operator, right? So we think about somebody who's very, very, high-level, skilled military personnel, a race car driver. I mean, there's so many of these, right? These areas where you got somebody who has years of training, is able to function and make these split-second decisions that really work out well. So we want to honor that, but always meet them where they're at. And one of the main things is creating an environment of safety, right? Start to develop some sort of trust that they're going to want to share their experience. So, with that, there's some of the general things, and then there's the specifics of that person's life. So that's a couple of thoughts right off the bat.
Well, thank you, David. There's one thing I think that people have to be aware of in the audience. We all expect our surgeons to be perfect and all of the operations to go well, but you have to understand that a surgeon is faced with decisions sometime on a split-second basis and has to make a decision. So it's often been said of surgeons that they're frequently wrong, but never, ever in doubt. Just like an airline pilot. Something goes wrong, they're going to make a decision. It's not always going to be the right decision. So I think that one of the things that I tried to emphasize when he came back from the therapist was to remind him that these things do occur, and that this isn't this is something that happens. It's something that occurs to all of us. So what would you say, David, about the amount of time that this person takes off, and should they go back into the operating room with a colleague and that type of thing?
Yeah, that's a great question, and it's something that so often we have to address is this person interested, and are they getting that institutional support? Like you give this example of giving that, it goes a long way. The manager, the supervisor, colleagues encouraging, and you just said exactly what we'd recommend, right? It's that sort of thing of going back into things with the support they need, with a trusted colleague, to really essentially, and this is when it comes to the proverbial, getting back on the horse, getting back in the saddle. We always, while it's a bias of mine, that we really want to help a person get that behavioral side, that remembering, back, you got to get back in the saddle to remember how you do know how to hold the reins, so to speak. You do know how to do things well. And you can talk about that forever, right? And we can do a lot. It's important that you do the cognitive work, right? Sort of address the ways that our mind is sort of run with this thing and kind of overblown or underblown certain aspects. But when it comes down to how we address trauma in the body, one of the ways that we address that is getting the body back in the world, back into that setting. And when I think about this and working with people like this, it really is that sense of, so it's not someone, much less me, but an expert who reminds them of their skill, all their years of training. That isn't going to have nearly the effect, right, as being, and you've probably seen this, right, as a first or a second in the operating room, that it goes a long way, because then your body, oh yes, and it's like you don't have to need to talk about it. Yes, I can do this. I'm capable, and so you're rebuilding that. And in terms of the amount of time, I think one of the things that we always want to be, aware of is don't wait too long, right, to get back into things, right, because the mind might just really start spinning on, again, some of the thinking that's not really accurate. We want to get that behavioral relearning going again, and that'll build that confidence. It so often does.
Well, and this is, again, I'm telling you, this is a real story.
Yeah.
And what happened in this case was that this therapist really worked some miracles with this doctor, got the doctor to take some time off, but not too long, 6 weeks, and then back in the operating room with a trusted colleague, where that doctor worked with that colleague for the next year or so in laparoscopic procedures. Now, the rest of the surgical procedures, this surgeon did very well, and the surgeon was skilled and had a perfect record. But he did something even more incredible. First of all, he developed a technique, an instrument with that trocar, a way to prevent probably this ever happening again, of piercing the aorta with this trocar. And he wrote this up. He wrote up his story. He wrote up this tragedy. He published it. He presented it at a medical meeting. And to this day, his terrible experience continues to help other people, and as they say, it keeps on giving. His gift, which turned out from a terrible incident, keeps on giving. So it had a very happy ending. Now, David, I'd like to switch gears. There is another surgeon, and again, this is a real story. This surgeon operated on a young woman during a laparoscopic cholecystectomy, and this was a very highly skilled cancer surgeon, and what happened is that he pierced the aorta with a trocar, but a very aggressive approach. He got inside the abdomen, he sewed up the hole in the aorta, and he was congratulating himself and everybody around him for saving the day. But 12 hours later, the lady developed bilateral dead legs because there was no circulation to her legs, and it now had been too long to correct, so she had bilateral above-knee amputations. Wow. The surgeon was blaming everybody and everything else. He tried his best. He exerted all of his skills, and it didn't work. So he was brought into the chief, and the chief said to him, let's discuss this. This shouldn't have happened. And again, he was very arrogant and adamant and blaming everybody and everything else about it. So the chief of surgery says, I have no recourse except to suspend your operating room privileges until we can sort this thing out and achieve some resolution. And as you might expect, in the meantime, there was a terrible lawsuit that ensued with a lot of angriness and hostility back and forth. The surgeon championing how great he was, and of course the family had this terrible loss. And so, if that, one of the things that the chief then did was the chief said, you've got to seek counsel. So I'm going to refer you to this clinical psychologist. And now, David, you're that clinical psychologist in this case.
Well, in many ways, right, it's the same, it's so similar, except for, you're speaking to something which is so important, is the attitude of that individual. One of the things the first thing I think about is, besides obviously just meeting that person where they're at, giving them the space to, they need to talk through their resentments or the frustrations with maybe how they're being dealt with or whatever it might be. But that sort of arrogance, you're alluding to, that sort of attitude, that necessary high level of confidence and even arrogance of the surgeon, that it's necessary in the sense to perform. And you see that, of course, in lots of different fields and people functioning at a high level. It's based upon reality, and it's also a very protective and powerful force for someone like that, someone who has to make so many decisions. One thing that comes to mind is if we turn over that arrogance, we might find, and I would think that it's a common thing, that it's around trust, right? If we're feeling very full of ourselves around competency with something, a strong confidence, and I'm the best at this thing, and this couldn't have possibly been my fault, and we look for blame otherwise. Oftentimes, what we're dealing with is connecting to a sense that we, through many years of training, excellent skill, have developed a very strong trust in our own abilities. And when something so tragic like these things happen, either of these cases, you have this natural thing of the rending of that trust. Besides that the organization, right, this is a questioning trust, but that internally, it's natural that a person's gonna, and that, like you're saying, it could be sort of deadly, as it were, to the career of a surgeon. And so that, I think in the therapeutic realm is so important to sort of respect, right? That is an avenue perhaps of important healing that we got to talk about. And sometimes you got to get through some of that, the hard feelings and the rest of it to get to that. In the second case, that might take a little bit more time. And so that's but I want to come back to something you said a minute ago about the other case. I think it's very powerful and something that doesn't oftentimes get discussed very much, is the connection between that personal growth process, the previous case, right? So the individual goes through their growth, they feel compelled to change and improve a system, a program, come up with something else. So you have individual level trauma growth connecting to a kind of community level innovation. And in medicine, it's ripe, right? You get medical innovation that comes out of it, and it's a pretty incredible thing. Whether or not that's something that the person is focused on, they may just feel, like I say, compelled to do it for their own growth, but then they essentially grow the whole community. And I think you see that in medicine probably a lot in the history of medicine, and you see it other places too. Certainly, I think it's happened many times in the military context as well.
Well, thank you very much, David. This has been very informative, very tragic situations. Now, the postscript on case number 2, unfortunately, is because of the legal action and because of pressure from the community and the hospital and so forth, this man never walked into the operating room again. As a matter of fact, although he was a trained surgeon with many years of experience and a high level of skill, he left his practice, he left the academic center, and he went to a small seaside town as a country doctor. And he was able to function there for the rest of his days. And it's very interesting because there was a show on television, a series about a doctor who all of a sudden became afraid of blood, and went to a small seaside town. So it was very interesting, and it's ironic that happened to this person.
I think one footnote on that is, I think so often it is important that people learn when it's time to say, it's time to get off the truck, as it were, working with first responders, get out of the squad car, just to that when it's time, it doesn't mean life is over. There's ways to live the value of whether it be service or to use that medical knowledge and help of others in other settings. But it can feel sometimes very a tremendous thing to ask of ourselves, and that's why it is so important, right, to talk to somebody, to counsel to them, both a colleague and a professional, because we need help, right, finding that path to the next thing.
All of
so
us
often.
need to do that.
Yeah.
So I'd like to thank Dr. David Faigin. Again, you'll see why it's such a treat to have him as a part of the family. And I'd like to thank all of you viewers for watching this. And we'd be happy to take your comments, positive and negative. I would like you to stay tuned for the next YouTube video. You don't know when or where. So thanks very much. And I hope you all have a wonderful day.